Well, first of all, it's my honor and pleasure to welcome you all here. This is an important session. You represent countries around the world who are part of us. You are all colleagues, friends, officers, students in the AUN, and we welcome you. This is today's session is under the AUN discussion. So I'd like to continue that. Essentially, when we started the AUN, we talked about these required modules, which is vascular, neuro-oncology, pediatrics, trauma, functional, spine, and neuroimaging. As further discussion undertook, and as we emphasize the importance of research as a central core for the field of neurosurgery, we decided to include research as a core component, actually. Okay. Just allow me 1 second here. So we established the Research Institute, okay, and both Melanie and Jack are represented here as the co-directors. The Research Institute, the aim, what we're trying to achieve here, okay. Excuse me 1 second. Let me let people in who are waiting. My apologies. Okay. Okay. Share again. Apologies for that. The aim is to create multi-center, multinational clinical projects. And that is a central aim for us. When we say multi-center, I just want to make sure everybody really is with me here. So multi-center, and then we're talking about multinational, okay? What do we say by multi-center? Most of the research that people like me have published are in one center, one hospital. So the cohort is very small. So we want to have large cohorts where you guys, as our members, officers, students, collect data in multiple centers around the world to have a large cohort. That means making the study a lot stronger. And by that, we also mean multinational. Okay. All right. So how will this work? Essentially, we're going to have neurosurgeons serve as PIs, principal investigators. Okay. Neurosurgeons from around the world. All right. And essentially, why this is, for most neurosurgeons, there's a restraint on time, the amount of work that neurosurgery requires. And as I said, the cohort is quite small. So these two have created a challenge, okay? To deal with this challenge, we have created this research institute where we will have the neurosurgeons will have a team that will work with them and will have large cohorts. The teams will be our students, actually, students and residents who will be part of the team collecting that data. So these are going to be large projects. Okay. The system we have set up is as I said, we have two co-directors, Jack and Melanie. We have a number of divisions that deal with quality and patient protection and all those issues. We have neurosurgeon-initiated projects, which we call they are the PIs. Okay, right here. we have resident-initiated projects and medical student-initiated projects. For all three, the PI will be a neurosurgeon, and we're gonna do all that matching, okay? We have already communicated with neurosurgeons around the world, and we have close to now 200 submissions of major projects by neurosurgeons around the world who want to start projects in the AUN. So we're very honored and privileged by the response by neurosurgeons from around the world for this, okay? So that brings me to our talk today and what we're trying to do. So essentially, what we're doing is this: we have established a group which is going to produce this research. So before you get into the research, we're going to have a module that everybody will have to take to be in this research projects, and this module will teach everyone the principles of research. So there are three main elements that we're gonna talk about: is design of studies, okay, biostats, okay, and thirdly, how to write a paper, how to review a paper, what are the ethics of research, how to do background research. So these are the three main elements of this module. This module is gonna be short, not like the current vascular and skull base I'm doing. It's going to be probably about 6 weeks. It's going to be 1 hour a week. And it's going to give you the principles that you have to know that most of us were never taught before we did research as to how to start with us in this journey. Okay. So that brings me to our invited speaker today. And I wanted to introduce him before we start here, okay? And sure, I have it admitted here, okay. Sorry, there are people waiting. All right, so for me, we needed a senior advisor for the research module, okay? And our senior advisor is gonna be Dr. Esene Ignatius, okay? I want to just say a few things about him. It really fits the leadership model I have talked to many of you about over the last few months. We have you here for many reasons, besides academics, research, also leadership development. And he typifies that issue. I met him some years ago when I was doing an invited lecture in Cairo, Egypt, and he did part of his residency there, and I met him. He stood out clearly. He went on really to follow a very unique path in the field of neurosurgery. He had additional training in the United States, but what he did was something no one has done before. He started to ask the question, how are neurosurgeons doing research? And how is this research being categorized? And do we all understand? Because most neurosurgeons, most of us are clinicians, okay? And there's a lot of question if everybody who's conducting research and putting the data together actually understands how all this research is done. So he started to do a number of things. He published a number of papers explaining this topic, questioning the model that exists currently in neurosurgery. And he has held major webinars, and as well as a major collaboration with the Global Neurosurgery Journal and major issues discussing this topic where he took a lead, okay? So he really has unearthed a concept that a lot of people don't understand everything about research, even though those people doing clinical research. In this journey, Dr. Ignatius has authored more than 100 scientific publications. He's a co-founder and deputy editor-in-chief of the Journal of Global Neurosurgery. He's a co-founder and scientific editor of the Pan-African Medical Journal, Clinical Medicine. He's a managing editor of the Egyptian Journal of Neurosurgery. He is on the advisory board of the Journal of Neurological Sciences. He's on the editorial board of Acta Neurosurgica. He's a reviewer for top 5 neurosurgical journals. that's beyond his titles that we sent you, okay? So he's a man, he's someone I'm very proud of because he represents the future. He represents coming from limited resources in Western Africa, how you can emerge if you are strong and you have the right ideas. You could do what it takes to become a leader. And he really sets the model for all of us to what leadership is about and what contributing is about. So we're honored to have him as the senior advisor to this research module that's going to be developed here over the next few weeks for you. And today we've asked him to give us kind of an introduction lecture, a large picture lecture about study design. Ignatius, I'm honored to have you.
Thank you so much, sir. Thank you. Can I share my screen? Okay, good evening to everyone. It's a great honor and pleasure for me to be here with you this evening, 6 p.m. Cameroon. And I'm short of words to describe how much I'm feeling this evening to talk in front of a very large audience of medical students. I've been doing it over and over, but this is very special to me because I'm invited by someone who inspired me to be what I am today. I met him on the 21st of March, 2013 in Cairo. I mean, you can see the picture I took. He is not only a mentor to a whole generation of neurosurgeons, but he is an innovator, a creator. I mean, he has discovered so many, he has created so many surgical techniques. And because of the way he makes us see neurosurgeon, he's an inspiration and a motivator to us. And as I said before, he has a wide influence on a whole generation of neurosurgeons. So it's a great honor and pleasure for me to be here with you today to talk in front of Professor Selim Abdurrahov. Without much ado, there is no conflict of interest. All the material I'm going to present here are part of the work we've been doing over the past decade. Well, I'm a proponent of evidence-based medicine. I mean, I believe that decision-making in neurosurgery should be guided by evidence. I believe that patient care, to give patients optimal care, this should be guided by evidence. So most of the things I'm going to be presenting here are based on the principles of evidence-based neurosurgery. I know most of you are interested in the neurosciences, from what I understood before I prepared this lecture. So most of the examples I'm going to give are in the domain of neurosciences. I know some of you are going to become neurosurgeons, some of you are going to become neurologists, neuropsychiatrists, and so on and so forth. So most of the examples are based on neurosurgery. Neurosurgery is a very challenging specialty. It is a specialty which is called an elitist specialty. But unfortunately, research has not yet been inculcated into the domain of neurosurgery. Research in neurosurgery is generally of very low quality. About 80% of neurosurgical research is of level 4 and 5. I'm going to talk about this maybe in our subsequent lectures. Level 4 and 5 means that most of the evidence in neurosurgery are based on expert opinion, case reports, and case series on cross-sectional studies. So it's pretty very low. And if you add level 3, which is case control study, and level 4, which are cohort studies, then up to 95% of neurosurgical evidence comes from just observational study. Just about 2% comes from randomized surgical trials, randomized clinical trials. So you see, there's a lot of work to be done by neurosurgeons to improve on the quality of research produced by neurosurgeons across the world. And that's why I'm talking to you today, to be able to stimulate you to be able to involve early in research so as to improve on patient care and policies in neurosurgery. I would like to show this slide because I think most of you are from low-income countries. And if you notice from this graph, up to 75% of research comes from high-income countries. So most of the research comes from North America and Europe, and the rest of the world is left with very little to show for. That is why I'm so much interested in research, because if you look for example, in a topic like traumatic brain injury, we all know it is very common in our settings, in developing settings. But most of the cases of traumatic brain injury, about 70%, are found in our settings, in sub-Saharan Africa, Southeast Asia, Latin America. But more than 80% of evidence comes from North America and Europe. So it becomes very challenging to develop guidelines to which are going to give us evidence to provide, to give optimal care to our patients. And that is why we are strongly recommending that young neurosurgeons or young neuroscientists in low-income countries should be actively involved in research, because it is only through research that we're going to be able to change the future. The goal, our big picture, is to develop what we call the physician scientists, the surgeon scientists. the surgeon scientist. That is somebody who is not only going to be focused on treating patients, but is going to be involved in education and training, research, and most importantly, in global health. That's to say, somebody who's going to be a clinician and a public health specialist. And I hope in the next coming years, I'm going to be happy to see most of you involved in this, sharing this vision. But we all know that this is totally different from what we see in LMICs and high-income countries. In the industrialized countries like in North America, Professor Selim Adyarov is a typical example. It's an epitome of what I'm talking about. He does cerebrovascular surgery. He does good skull-based surgery. He's an educator and a trainer. I mean, you've seen him move across the world teaching young neurosurgeons and medical students. He's a researcher. I mean, you've seen from his publications. And he's also involved in global health, like what we're talking about today. We want to impact the community, we want to induce social change. When you come to our settings, most of the neurosurgeons are in this scenario. They spend a lot of the time, up to 80% just treating patients and little or no time for research and education. And this is a very big issue. And I keep on telling them that we need to change this mentality, because this is a traditional way to neurosurgery, which is no longer relevant today, the year 2022. So therefore, there are a lot of things I want to talk about today, but I want you to understand that I didn't just come up with this idea from empty space. I was motivated by something, because when I started doing my training in neurosurgery, I realized that there were a number of things which were not correct. And I'm somebody who believes in quality. I believe in quality over quantity. And do you know that up to 15% of studies published in neurosurgical journals, I mean the top 30 neurosurgical journals as case reports are not even case reports? So these are a misclassification. Up to 70% of studies published as case series in top 30 neurosurgical journals are not even case series. Up to 50% of studies published as case control studies are not case control studies. About 50% of studies of surgical trials published in neurosurgery are of bad to moderate quality. And up to 1/3 of studies that are published as meta-analyses do not even meet the basic definition of a meta-analysis. So you see that these are real issues. And this becomes a problem, because to be able to provide care to the patient, today we need to apply the principles of evidence-based medicine. Evidence-based medicine is based on a number of pillars. We have the best research available evidence, okay? The surgical experience and expertise, patients' values and preferences, and the local plateau technique. But you see, if the evidence is flawed, the basic evidence is flawed from the primary studies, then the decision-making on patients is also going to be flawed. So that's why we have to understand the anatomy and physiology of this basic study designs in neurosurgery. That's why today I have 4 key objectives. The 2 are the most important. You need to understand the simplest approach to study designs in clinical research, understand the anatomy and the physiology of common study designs. Then you need to understand the relationship between study design and biostatistics, because when you collect data, you need to summarize this data for people to understand. So you need to understand biostatistics. And then to be able to translate this to patient care, you need to understand the concepts, basic concepts in evidence-based neurosurgery. So these are the 4 things we'll be discussing this evening. Research is generally classified into bench research, okay, and bedside research. Bench research is what we do in the laboratory, okay, and bedside research, clinical research is what we do to improve on patient care. Today, we are going to focus on clinical research. Clinical research is generally classified into quantitative research and qualitative research. I mean, subsequently in future, we're going to talk about qualitative research, because just 2 papers have been published in qualitative research. This paper of ours and another paper which I'm going to share with you. And so most of the evidence from neurosurgery is based on quantitative research, as I'm going to show you, demonstrate very shortly. So the first paper we published on qualitative research, which is the first in neurosurgery, tells people that we need to explore this avenue, because qualitative research methods are complementary to quantitative research designs. So this was the first paper we published, and the next paper that we did was this one that shows the value and the potential of qualitative research methods in neurosurgery. So we're urging the new generations not to just to be focused on quantitative research designs, but they should also focus qualitative research methods. And I'm going to help you to make this happen. So without much ado, I'm going to start with I like the problem-oriented approach. We look at the problem and then we look at the solution. The first problem we detected was that there are many confusing approaches to study designs in neurosurgery. If you look at, say, 50 textbooks of clinical research and then maybe 100 papers, you're going to see totally different approaches, and it makes it difficult for the novice to understand how to approach research. So that's why we developed something to be able to help young neuroscientists to be able to understand the simplest way to look at research. I'm not going to go into this because we don't have so much time, and I'm going to focus on the algorithm which we developed, okay, to help young neuroscientists to understand a much more simplified way to research designs in neurosciences. So this approach is very simple, as I'm going to show. It's based on a number of questions which we're going to ask. By the time you answer these questions, you're going to understand how, or the easiest way to approach research. So, but before I talked about that, we published our paper in 2016, but I was surprised that in 2017, a paper was published in Journal of Neurosurgery, which is, I mean, one of the top journals. And this algorithm was similar to us, but had a lot of methodological flaws. Okay, I mean, the authors classified research, quantitative research, into primary and secondary, which is very correct. And this is the approach which we used earlier in 2016. And then they come forth to talk about descriptive and non-comparative study and analytic and comparative. This is tautology, because when you talk about descriptive studies, it means it is not comparative. When we talk about analytic study, it means it is a study that involves a comparison group. The next thing they talked about, which I don't agree with, is on descriptive studies, they mentioned just a case series. Shortly, you're going to be seeing me talking about other types of descriptive studies. So descriptive studies are not only limited to case series. There are other types of descriptive studies, which I'm going to talk about. On observational studies, they just talk about the cross-sectional study, and then they talked about longitudinal study. This is a terminology which I will not like us to talk about because it's very confusing. A cohort study is a longitudinal study. A case control study is a longitudinal study. Even a randomized clinical trial is a longitudinal study. So when you say longitudinal study, it's very confusing, and I'm going to explain this to you very shortly. And then they even went forth to talk about a prospective cohort non-randomized control trial. I mean, there's no study design in research called as such. So this algorithm is, for me, is not correct. I mean, I'm sorry to say so. So this is the algorithm which we developed, which we just published again a few months back in the World Neurosurgery. And this algorithm of ours is based on questions which we are going to look at. So this is the most important thing that you need to understand this evening. So when you pick up a paper to read, as a young neuroscientist or somebody who wants to get into neurosurgery, or you want to conduct research, the first question you have to ask yourself is, what is the goal? What is the aim? Okay, do I want to go into literature and collect data that's existing and then just summarize them together? And then in that case, we're going to be talking about the reviews, okay? But if you want to collect new data, okay, and analyze them from data from patients, okay, and analyze, then we're talking about primary research designs. And most of the studies we're going to be doing with Professor Selim Abdurraouf, be them the multi-center study or the multinational studies, are going to be the of primary research designs. So the first thing is, what is the goal? We need to collect data, new data, and this data is going to be analyzed to produce some results. So we're talking about the primary study design. The next question you need to ask yourself, is there a comparison group? Or I'm just going to look at a single group of patients, okay? If there is no comparison group, we're talking about the descriptive studies, okay? Descriptive studies, no comparative group. If there is a comparative group, then we're going to be talking about the analytic studies, okay? We go to the descriptive studies. We look at what is the unit of analysis. Are we going to be looking at the effect of the exposure at the population level? For example, you want to look at smoking in Los Angeles, or you want to look at alcohol drinking in Berlin, okay? Without going into the individual data of the subjects. We're talking about ecological studies, okay? But if you have to collect data about individual subjects and analyze, then the different types of descriptive studies you need to know, and which I'm going to explain to you this evening, are the case reports, the case series, and the descriptive cohort study. And I want to underscore here that the descriptive cohort study is a study design which was introduced in the neurosurgical lexicology by my team. So before then, this study design was not yet known. Then when you go to analytic study means there's a comparative group. The next question you need to ask, who is allocating the exposure? Who is allocating the intervention? Is it the investigator, the researcher? If the investigator is just going to observe the patients in the natural environment, we talk about observational analytic studies, okay? But if the investigator is going to allocate the intervention, okay? Don't worry, I'm going to explain this in details shortly, but we'll talk about experimental studies or the intervention studies. Now, when you come to observational studies, there are two things you need to understand, which I'm going to explain to you in the next few minutes: the word exposure and the word disease, okay? For surgeons, the words are the intervention and the outcome. So if a patient comes to me and I have to operate the patient using a microscope, the microscope is a tool which I'm going to use. So it is microscopic, say, discectomy, or microscopic endoscopic removal of a tumor. So the microscopic technique is known as the exposure or the intervention, okay? And then if maybe I'm talking about a pituitary adenoma, we want to see the effect on the hormonal remission or the gross tumor resection, that is the outcome or the disease. So if we're studying the intervention and the outcome at the same time, we're talking about the cross-sectional studies or the transverse studies, okay? But if we're starting from the outcome to the exposure, we're looking at a patient that have a complication rate, they want to look at the surgical technique which they had. We were talking about the case control studies, okay? If we are starting from the exposure or the intervention, and then we follow up the patients in the future to see the outcome, we are talking about the cohort studies, okay? So these are the different observational studies which you need to know. I'll go into the different studies to explain to you the anatomy and the physiologies. Okay, of course, I talked about the secondary study designs, which involves the reviews. And at the top of them, we have the meta-analysis, which is a review with some statistical analysis involved. Okay, quite recently, this is what we call the overviews, which are systematic reviews, meta-analysis of systematic reviews and meta-analysis. So a paper which we published recently, we looked at observational studies in neurosurgery. Okay, we looked at the anatomy and the physiology and how these studies can be conducted and reported. So we are going to start with the basic study design. We know in the nervous system that the neuron is the basic structural and functional unit of research or of the nervous system. The case report is a basic structure, it is a basic unit of research. Okay, so but as I told you before, up to 50% of studies published in neurosurgery as case report are actually they are investigation. So what is it? What is a case report? How many subjects is enough to be described as a case report? Because this has been the point of contention. For you to look at this table, okay, these are papers published in top neurosurgical journals. You find the first paper, it is published as a case. The first paper is published as a case report. The sample size, that is the number of subjects involved in that study, is 11. Okay, you see the second study published as a series. The number of subjects involved is 4. So there's a problem because this case series is supposed to have a higher sample size than the case report. Here you see case report 11 series 4. You go to the next paper, it is published as a case report, sample size of 4. So you see that 2 papers with a sample size of 4, one is published as case report, the other is published as case series. So this causes this is a confusion which we needed to clarify. Okay, so this confusion has been existing for more than a decade, for more than a century. So based on our knowledge of biostatistics, okay, and mathematics, we know that there's a relationship between the confidence interval. You've often heard about confidence interval. I'm going to talk to you about that when we talk about the module of statistics, okay? There's a relationship between the confidence interval, what we call the standard error. The standard error is simply the standard deviation of the population. That is a measure of the spread around the central tendency statistics, okay? So don't worry about this. What I want to understand is that there's a direct relationship between the confidence interval and the standard error. And it's also an inverse relationship between the standard error and the sample size. So based on this, we're able to draw a graph between the standard error and the sample size. And we realized that at the sample size of 5, this was a marked change in the confidence interval, okay? We know that once this increase in standard error, the confidence interval is going to increase. And in research, we don't want the confidence interval to be wide. We want the confidence interval to be narrow because we want our effect size to be precise. So therefore, we say that for a study where the sample size is less than 5 subjects, this should be reported as case reports. And above that, you need to use another study design depending on the method of sampling. So this was a paper which was published in the World Neurosurgery, and it is our most famous publication. And this now has been adopted by most biomedical journals. It is now on the Journal of Neurosurgery. So for you to be able to publish a case report, size can vary from 1 to 5 subjects. So now, what is a case report? A case report for a surgeon falls under the 5 basic categories. It can be something which is unexpected during a surgical intervention or during the diagnosis and the management of your patient. It can be a surprising event, something which usually we're not expected to see during the operation. It can be an atypical event, an atypical scenario which occurs during diagnosis, treatment, and follow-up of your patient. It can be a unique or a rare feature of a disease. Maybe we know that maybe a lumbar disc is going to present with maybe low back pain. But you find a lumbar disc presenting with maybe thoracic pain. It's something which is abnormal. You need to find out why that is happening. It can be an exceptional creative extension, okay? A new surgical technique. So all these, they fall under what we call the case report. But what we added new to the definition is that the sample size should be less than 5 subjects. So this is what we added into the neurosurgical literature or into the biomedical literature. And again, sometimes in journals, studies that are published as case reports can be brief reports, adverse effects, letter to the editor, how I do it, clinical notes, and case studies. So all these are usually considered as case reports. How do we write a good case report? In 1983, a paper was published by DeBeke, okay, where they outlined that to write a good case report, you have to use a 5-level plan. Okay, the introduction, description of the case. Okay, discussion, review, the summary, and conclusion. But presently, there has been the development of what we call the CARE guidelines. CARE stands for Case Reporting Guidelines. And every neuroscientist, I urge all of you to go and read about the CARE guidelines, okay? Because for you to be able to write and publish a good case report, you need to be able to apply this checklist to your case to see if it has been appropriately written. Having understood what is called a case report, we're going to move to the next level, which is the case series. What is a case? There are two basic kinds of case series. Okay. But case series is a neglected design in surgery and in neurosurgery, because if to PubMed is a database where you can find many articles published, okay, it has a lot of articles there. Every study design has a mesh term, okay, but surprisingly, there's no mesh term for case series. So when you type case series, there's no mesh, which means it's a neglected design. People don't find it very appealing. That's why much has not been spent on studying this very particular study design. And that's why we've been working on it for the past years to make people understand the anatomy and the physiology of this study design. So when we evaluated study case series published in neurosurgical literature, we realized that up to 70% of studies published in neurosurgical literature as case series were actually a misclassification. Okay, just about 30% of them were true case series. So this is very, producing flawed research. Okay, actually more than 50% of them were what we call descriptive cohort study, which I'm going to explain to you. And this paper was published in Child Nervous System as a cover editorial. I mean, imagining me publishing a cover editorial when I was still a resident, this was very rewarding. So to be able to understand what a case series is, you need to understand some terminologies in research. This is a paper which I published with some of my medical students here in Cameroon and in Africa. Okay, there are some 4 terminologies which you need to understand. The word expose, which I mentioned before, non-expose, cases and controls. So we're going to begin with that. Expose or the exposure, it is any, I'm talking about surgery and neurosurgery. It is any intervention to which individuals are subjected to. It can be a surgical procedure, okay? It can be a behavior like smoking or drinking. That can be considered as an exposure, or an individual attribute. For example, age. You can say the pediatric age, the adolescence or the youth, and then the geriatric age. So this can be classified as such, put into groups. So this can be an exposure, and you compare what is happening to these different age groups. It can be sex. It's comparing what is happening between the males and the females. So in that case, sex is considered as an exposure. It can be the race, okay, the blacks, the white, and the colors, okay? So common exposures in neurosurgery are the different surgical techniques, okay? An exposure may represent a new surgical technique. For example, we know that for a very long time ago, we used to use the microscope to do most of our neurosurgical procedures. But recently, in the past few decades, there was the introduction of the endoscope. So if you are comparing the endoscope, which is a relatively new technique, that's going to be the exposure, okay? And then the non-exposed group is going to be what the gold standard approach, which was used before, like the transcranial approach. That was my topic. So the concept of exposure and the non-exposed, okay, is in surgery, it can be likened to the new surgical technique and the standard technique, which has previously been used for that pathology, okay? Exposure can be dichotomized or even trichotomized, okay? And it can be even graded into levels. For example, pain, you can talk about mild pain, moderate pain, severe pain. So that can be an exposure, even blood pressure or intracranial pressure. So there are so many ways to look at the definition of the word exposure. So as I said, for surgeons, the word we use is intervention. So we have intervention A compared to B. Usually A is always the new technique and B is the standard technique, and which is the gold standard for that procedure. The next thing you need to understand is what we talk about, the disease or the outcome, okay? In surgery, when you operate a patient, maybe coming with a brain tumor, maybe the patient presented with headache, you expect the headache to resolve after surgery. So we want to see what is going to happen to the headache after surgery. So that's going to be the outcome. When the patient comes with a tumor, you want to remove the tumor. You want to see how much tumor was resected. So that is the outcome, okay? So the outcome refers to the disease state or the event, for example, the complication rate or the recurrence, okay? The behavior or the condition associated with the health that is under investigation. So common outcomes or disease state of in neurosurgery are the degree of tumor resection, the complication rate, or the recurrences. There are some terminologies there you're going to see when you talk about research. You're going to see the word prospective, retrospective, okay, longitudinal. These are terminologies which I don't like to use very, very much, but I'm going to explain to you why it's sometimes very confusing to use these terminologies. We've already talked about exposed and the non-exposed. We talked about exposure and the outcome. So there are two ways to look at the word prospective and retrospective, okay? When you're talking about directionality, if you are sampling, if patients are entering into your study based on the exposure or the intervention, okay, and then you want to evaluate to see the outcome, generally the word prospective is used. Okay, that's why most of the time you see cohort studies are called prospective studies. That's why you see the trials are called prospective studies. Okay, that's with respect to directionality. But if you're moving from the outcome, okay, patients having tumor recurrence, you want to look back into time and see if they were operated using the endoscope or the microscope. They were talking about retrospective in terms of directionality. We're moving from the outcome to the exposure. So prospective, we are starting from the exposure to the outcome. Retrospective, in terms of directionality, we're starting from the outcome to the exposure. And then when you talk about the transverse studies or the cross-sectional studies, we're looking at the exposure and the outcome at the same time. So that is why in some literature, you're going to see here cohort studies likened to a prospective study, a longitudinal study, a follow-up study. Is simply because we start from the exposure or the intervention and follow up the patient to see the outcome. Then you are going to see studies like the case series or the case control studies called the retrospective study, because we are starting from the outcome and looking back at the exposure which occurred in the past. Okay, and then the transverse studies that are translational, we are looking at the exposure and the outcome at the same time. So in cohort studies, participants are selected on the basis of the exposure status, while for case series and case control studies, sampling is based on the disease or the outcome status. The next word which you need to understand is the word cohort. You know, I like to use this example. So this is a group, on this video, you see a group of army, okay? In the ancient Roman time, a cohort simply used to mean a group of army starting at a particular point and heading in a particular direction. So it was called a cohort of army. So in the Roman time, it was called an infantry. So an infantry was just a collection of 300 to about 600 soldiers who started at a particular point and aiming to a particular direction. But in epidemiology or in research, okay, cohort is a group of people a group of subjects that have something in common. Usually the exposure or the intervention. Then they are then follow up over time to see the outcome or the disease status. A case was derived from the Latin word casus, which can simply be understood as a happening, an event, or an occurrence. Okay, so as I told you before, case can be likened to the outcome. But sometimes when you're in the hospital, for most of you, you hear somebody say, "Oh, I have 5 cases in the ward." This word cases is different from the word case used in research. In research, case means the outcome or the disease status of the patient, okay? But linguistically, a case means a patient or a person, okay? So strictly speaking, a case is the disease state or the clinical phenomenon which we want to investigate. So having understood this, I'm going to bring you to one important table again, which we call the epidemiology table. It's called the decision matrix. It is the most important table in research. And this is even how most statistical softwares look at data, okay? So when you're doing research, especially research that has a comparison group, as I told before, if you haven't said 2 groups, okay, which you are comparing, group A, you are going to call group A the exposed or the intervention group, and then group B is going to be the non-exposed or the non-intervention group, okay? And then when you give the intervention, the patients to the intervention, you follow them up to see the outcome, okay? Patients that are going to have the outcome are called the cases. Those without the outcome are going to be said the disease. Sorry, those are going to have the outcome are going to be known as the cases or the outcome or the disease. And then those without the outcome are going to be known as the non-disease or the controls. So the first kind of studies that we're going to look at is the descriptive cohort study, which was confused for the case series. With the descriptive cohort study, it's just a single group of patients, and we're starting from the exposed. We follow up the patient without comparison to see the outcome. For the case series, we are just looking at the cases, okay? Or the patients having the outcome. We look back into time to see the exposure which they had. So there are 2 types of case series. The first type of case series is what we call the epidemiologic case series. All of you know this kind of case series. And a frequent example which I use is like the COVID-19. When COVID-19 started in China, we had maybe the first few cases, maybe 1 case. We said, okay, this case was reported as a case report, 3 cases, case 5 cases, case report. But as soon as the number of cases went beyond 5, it has to be reported as a case series. So the difference between a type 1 or a type 1 case series and a case report is that the sample size for this type of case series, which is the epidemiologic case series, is the sample size has to be greater than 5 subjects. So this type of case series is just a collection of case reports. A case report is the basic structural and functional unit of research. And as I said before, it can be an unusual finding, a rare finding, it can be something which is unique, okay? But when these cases are more than 5, they should be reported as a case series, because with the case series, we can do statistical analysis. With the case report, we just give the raw data. We describe each of the cases individually without summarizing the data together. Case series, which we call the surgical case series. So I'm going to use this example to illustrate to you. Again, the sample size has to be more than 5 subjects, okay? And the sampling or the way subjects are entered into the study has to be based on the disease status or the outcome. So patients are selected based on the outcome. For the cohort studies, patients are selected based on the exposure or the intervention. So you see here this arrow stating to us that the direction of the study is from outcome to the disease. So to illustrate this, if you go to the oncology unit, okay, you select a sample of patients that were operated for a meningioma at the skull base called suprasellar meningioma, okay? And then you look back into time to the patient's file to see if the patients were operated through a transcranial approach or through the nose strips. We call it the endonasal approach. So this is the study design of a case series. So you have a single group of patients that were operated for suprasellar meningioma and having an outcome. And we look back into time, okay? See, the patients that were having tumor recurrence, were they operated using the endoscope or through the microscope? Were they operated using the nasal approach? So this is the study design of a case series. You start from the outcome here. The outcome here is the tumor recurrence, okay? And then you look back into time to see the intervention which the patients had. Was it a transcranial surgery or was it an endonasal surgery? The transcranial and the nasal surgery were the exposure, okay, and the non-exposed. So we start from the outcome and then we look back into time to see the intervention which the patient had. So this slide shows the difference between a descriptive cohort study and a case series. I've already explained to you what the case series is. We have a single group of patients with that outcome. We look back into time to see if they were exposed or non-exposed, okay? Now, for the descriptive cohort study, it is exactly the opposite of the case series, okay? We have a single group of patients that were operated for the tumor. We are not starting from the outcome of the disease. We are starting from the intervention. So we look at patients, for example, those that were operated using a microscope. And then we compare the recurrence rate, okay? What is the recurrence rate in patients that were operated using the microscope, okay? The microscope is the intervention. So the investigator simply goes to the department, look at patients that were operated for suprasellar meningioma, and they follow them up to see the recurrence rate. Okay, the recurrence rate is going to what we call the incidence, the number of people that are patients that are going to develop a particular outcome over a given period of time. Okay, like a complication rate. This is a probability. But with the case series, we start from the outcome, we look back into time to see the exposure which they had. Here, we cannot measure the incidence. What we measure is called the odds. The odds is different from the incidence. Incidence is a complication rate. Okay, incidence is a probability. Okay, the odds is not the probability. And I'm going to explain to you what it means in terms of statistics. Okay, consider here we have 12 patients, okay, with brain tumors. Okay, the ones in red, patient number 7, 8, and 9, they have a complication. Okay, the incidence of complication is going to be 3 on 12, which is 30%. Okay, 3 patients had complication, 12 patients were operated, 3 had complication. The incidence, okay, or the probability of having a complication is going to be 3 on 12, which is 30%. But the odds, okay, of having a complication, which is what we measure when we conduct case series studies, is going to be 3 on 12 minus 3, which is 3 on 9, okay, which is going to give us, going to give us the odds is going to be 9%, 30%, and the probability is going to be 25%. Let me take it over again. The probability is the incidence. It's going to be 3 on the total number of patients that were operated for the surgery. So it's going to be 3 on 12, which is 25%. When you look at calculate the odds is going to be 3, not on 12, but on 12 minus 3, which is 12 on 9, which is going to be 30%. So you see that 25% is totally different from 30%. So when you confuse a descriptive cohort study for a case series, you are going to produce a flawed effect size. So which is going to be represent the effect size that was measured. So that is what is very important to know the anatomy and the physiology of the different study designs. To be able to write good case series, we need to apply what they call the process guidelines. The process guidelines were developed recently, just not up to 10 years ago. Process stands for Preferred Reporting of Case Series in Surgery, okay? And to be able to write a good cohort study, you need to apply the STROP guidelines, strengthening the reporting of observational studies in epidemiology. Having understood the case report and the case series and the descriptive cohort studies, we're going to move to the analytic studies. We'll start with the observational studies. Cross-sectional studies are very easy to understand, and quite often it's not difficult for anybody to understand what a cross-sectional study is. With the cross-sectional studies, we're looking at the exposure, the exposed and the non-exposed, okay? There are those having the outcome and at the same time, at the same point in time, okay? There are cross-sectional studies, and most researchers understand the study designs. A typical type of cross-sectional study are the surveys, okay? Cohort studies also, the analytics type, that is the cohort study with the comparison group, is also not very difficult to understand, because we start, as I said before, the directionality of a cohort study is we are moving from the exposure to the outcome. So for example, you go to a spine unit, okay? You select cases that had disc prolapse. Group A, we operated using the microscope, group B through the naked eye, okay? So group A is going to be the exposed, and then group B are going to be the non-exposed. We then follow them up to see the outcome in terms of the leg pain, which is known as the sciatic, and the recurrence of the sciatic pain. So sciatic pain among those that were operated with the microscope, sciatic pain among those that were operated with the naked eye. So this is the study design, this is the anatomy of the cohort study. Okay. Another example is if you go to a neuro-oncology unit, patients that are operated for maybe adenoma, okay, using the endoscope, could be using the transcranial approach. You then follow them up to see the outcome in terms of tumor resection, in terms of biochemical remission, that is the regression in the hormonal levels, okay, in terms of morbidity and mortality. This is the study design of the cohort, okay, the analytic cohort study. The most difficult for surgeons is the case control study. As you can see, that up to 10 studies have been published addressing the issue of the case control studies in neurosurgery. The most extensive study was ours, because we looked at all case control studies published over the last decade in the top 31 neurosurgical journals. And we realized that up to 40.6% of studies published as case control studies are not actually case control studies. Okay, not every control study is a case control study. Researchers control the fact that a study with a comparison group should be a case control study. It is not a comparative, it is not a case control study. Okay, a cohort study, you have the exposed and the non-exposed. It is not a case control study. For the case control study, you are comparing patients having the outcome to those without the outcome, the cases to the controls, the disease and the non-disease. Okay, so again, if you look at our table for the case control study, we are comparing the disease and the non-disease. Okay, we are comparing the outcome to those without the outcome, okay? We are comparing the cases to the controls. So this is the case control study, okay? So to illustrate this with an example, if you go to a spine unit, okay, you look at patients that were operated for lumbar disc herniation, okay, back pain, low back pain, okay? You look at those that had CSF leak, okay? Because when you operate for lumbar disc herniation, you're not supposed to open the dura, okay? So sometimes you might advantageously maybe injure the dura, and CSF is going to leak. So if you compare patients that had CSF leak during lumbar disc surgery compared to those without the CSF leak, okay, those with the CSF leak are going to be called the cases, okay, or those with the outcome. Those without CSF leak are going to be called the non-disease or the controls. So since we are comparing the cases to the controls, this is the case control study. You then look back to time to see if the patients were operated using through the microscope or through the naked eye. This is the anatomy of the case control study. Okay, so we start with patients having the outcome, we compare those without the outcome. We look back into time to see the exposure which they had. Again, to understand the difference between the case control study, which is like a reverse of the cohort study, you need to look at these two diagrams. For the cohort study, which I explained before, you go to the spine unit, you pick up patients, okay, that were operated for lumbar disc herniation, okay, or you start a group of patients, a cohort of patients operated for lumbar disc herniation. Group A operated with the microscope, group B with the naked eye or with the loop, okay? You follow them up to see the outcome, example, recurrence of the leg pain, okay, in both groups. This is the cohort design. We are moving from exposure to outcome. For the case control study, we're starting from the outcome to the exposure. So we go to the same spine unit, we take the files, okay, patients that had CSF leak after disc surgery, okay, we compare it to those without having CSF leak, and then we look back to time to look see the exposure which they had, that is the intervention which they had when they operated with the microscope or the endoscope, when they operated with the microscope or with the loops. So this is the design of the case control study. And again, in terms of statistics, with the cohort study, what we measure is the relative risk. We cannot measure the relative risk with the case control study. What we measure is the odds ratio. Remember, for the descriptive cohort study, which is a cohort study without a comparison group, what we were able to measure was the incidence, okay, or the risk. For the case series, we're able to measure the odds. Now, for the case cohort and the case control studies, with the cohort studies, we're able to measure the relative risk, and the case control study, we're able to measure the odds ratio. These are two different things. They mean two different things. And again, when you confuse a case control study for a cohort studies, you're going to flow evidence, because if you look on this hierarchy of evidence, the cohort study is higher in the hierarchy than the case control study. So, okay, cohort study or a good cohort study is level 2, and a good case control study is level 3. So when you confuse a case control study for a cohort study, you're actually producing flawed evidence. So these are some of the misnomers which you're going to find in the literature. Sometimes they call case control studies as cross-sectional case control studies, case control cohort studies, retrospective case control. These are all misnomers, okay? Don't look at these things which are not correct, okay? So you either have the cohort studies and the case. Again, this table summarizes the difference between the cohort study, the case control study, and the cross-sectional study. For the cohort study, again, we are starting from the exposure, okay? We are going from the exposure to the outcome, okay? For the case control study, it's from the outcome to the exposure, okay? For the cross-sectional studies, we are looking at the exposure and the outcome at the same time. Worth noting is that a cohort study and a case control study can both be prospective and retrospective. I'm not going to go into these details, okay? But what I just want you to understand is that when you hear the word cohort study, know the point of inception or the point of how you enter study into a subject into the study is going to be based on the exposure or the intervention. For the case control study, subjects are going to be entered into the study based on the outcome or the disease state, okay? For the cross-sectional study, we're looking at the exposure and the outcome at the same time. To be able to write a good observational study, okay, the STRAP guidelines have been developed, strengthening the reporting of observational studies. You need to apply these guidelines to be able to report their studies appropriately. I'm just going to go rapidly over the surgical trials, because any person can conduct a case report. Anybody can conduct a case series. Any person can write a good case, a cross-sectional study, a case control study, or a cohort study. But to be able to do a good clinical trial, you need experts. Okay, you need people who have an expertise in a research method. Okay, but for you to, I just want to understand that in neurosurgery, or in research in general, the clinical trial is the gold standard for research. And in neurosurgery, it is the most controversial study design. Although reports show that there has been an improvement in the studies published over the years, up to 50% of surgical trials published in neurosurgery are bad to moderate quality. Okay. The major difference between the cohort and the clinic is that here, the investigator in the trial is the person allocating the exposure. So he's going to decide who is going to be subjected to microscopic surgery and who is going to be subjected to macro dissectomy. Whereas the investigator simply watches the subjects in the natural environment. It just follows them up without determining who is subjected to intervention A or intervention B, okay? And surgical trials pose a lot of challenges. You need to have a very large sample size, and you know, surgical pathologies, sometimes the sample size is very small, and which makes us to be able not to publish studies of very high statistical power. Sometimes it's difficult for patients to accept the new technique. For example, if you want to compare the endoscope to the microscope, patients might not accept the new technique. Well, they are afraid, they don't know about the technique. So sometimes these techniques are also very costly. To be able to do a good surgical trial, it needs a lot of money. So that's why surgical trials are very limited, and only 2% of studies in neurosurgery are level 1. To be able to do a good surgical trial, you have to apply the consult guidelines. Again, as I advise, if you want to do a surgical trial, you have to contact an expert in research. Okay, you have to consult the research methodologies, or somebody with a background in public health or in global health or in global neurosurgery. I'll end with to talk about the reviews. The reviews are very broad. As I said, they begin from the traditional reviews, which are very frequent most of the times an expert is invited to write about a particular subject. No particular research question is being answered, just a broad review of what is happening. Okay, you move through the scoping reviews, okay, then systematic reviews and the Cochrane reviews, which are actually systematic reviews, but differ from the classical systematic reviews, is that there's a protocol which has to be published before you actually start the review. Okay, they have the meta-analysis, which is similar to the systematic review, except for the fact that there's the pooling of data. It actually involves some statistical analysis. And then quite recently, you have what you call the overviews. Overviews are systematic reviews and meta-analysis, and these are quite recent in research methodology. Okay. Third of published a meta-analysis in the surgery do not even fulfill the basic definition of a meta-analysis. Okay, most of these are just what we call analogies mixed up together to produce some statistics, and we strongly recommend that young neuroscientists should be able to conduct meta-analysis, because meta-analysis, they are the zenith of the research evidence. Okay, so you should be able to know how to conduct a good meta-analysis. I'm not going to waste much time on this. This is a paper which we published recently, which explains how to interpret a meta-analysis in neurosurgery, and this also applies to other surgical specialties. These are some of the guidelines which you need to use to be able to do a good systematic review and meta-analysis. Okay. STAR guidelines help you to be able to conduct the study. The PRISMA guidelines help you to be able to report a systematic review and meta-analysis. And if the meta-analysis involves observational studies, they have to use the Morse guidelines. And then you also have the sample guidelines, which helps you to see if the statistical methodology was good or not. Before I end, I would just want to show you the relationship between the study design and the statistics. As I told you before, once you're conducting research, contact the research methodologist, contact the biostatistician early enough in your study. Don't wait until when the data is collected before you contact the statisticians, because sometimes the data might not be collected appropriately, okay? Because each time you conduct research, there's a particular effect size which has to measure for a particular study design. If you're talking about the case series, then you should be able to calculate the odds. If you're talking about the descriptive cohort studies, you should be able to measure the incidence, the risk. If your study is a cross-sectional study, you should be able to report the prevalence. Case control study, you should be able to report the odds ratio. If it's a cohort study at the surgical trials, you should be able to report the relative risk. Okay, even though, as I always say, if you do multivariate analysis in cohort studies and surgical trials, you can also report the odds ratio. At the end of the day, the aim of doing research is to improve on patient care, is to be able to develop good policies. And this can only happen through the process of evidence-based neurosurgery. Evidence-based medicine, as defined by Saget in the early 90s, is the conscientious, explicit, and judicious use of current-based evidence in making decisions about individual patient care. It simply means it is the integration of the best research evidence, surgical expertise and experience, patient values and preferences to provide optimal care or optimal policies for patient care. These are the guidelines which you need to know. Go to Google, type on Equator guidelines, enhancing the quality and transparency of health research. Every young scientist, every young physician, every young neurosurgeon, every young doctor should know to read and understand the basics of the Equator guidelines, because this is going to help you to be able to do good research. I started introducing research to young African medical students because I believe that to change the scenario in Africa, we need to introduce medical students very early enough into clinical research. In our settings, most of the times, medical students get exposed only when they have to finish their end of year program. That is, they do a thesis at the 7th year, which is already late. If you go to North America, you see undergraduates already doing a lot of research. Okay, so that's why we try to look at this and try to encourage young medical students to be able to engage in research very early enough in their careers, although there are challenges which we face in our settings in the LMICs. So at the end of the day, what we want to do, what we want to change is the scenario here. We want to change this scenario. This is the scenario we want to change, okay? To this scenario on the right. We want physicians, we want doctors, we want surgeons who are involved in patient care, education and training and research, okay? We also want to encourage researchers from low-income countries, because for us to be able to close the gap between high-income countries and low-income countries, we need to provide data. This problem is not going to be solved by researchers from high-income countries. They're going to come into our settings, collect data, analyze, and go back to their respective countries. We need to be able to change things in our settings. And for this to happen, young medical students, researchers, and trainees should cultivate an evidence-based approach. they should understand the basics of study designs, biostatistics, and the basic concepts of evidence-based medicine. Thank you so much. These are my social media accounts. You can follow me up on Twitter, Facebook, and LinkedIn. And I'm looking forward to hear your questions. Thank you so much.
Thank you so much, Dr. Ignatius. What a yeoman's job you did to cover so many things in such a short time. Only you could have done that. So I really, really appreciate your effort, what you're doing for our field of neurosurgery and teaching neurosurgeons to understand study design better. So I think this was a great introduction for our teams. Our aim is to produce this module that will be about 6 weeks. So all the idea, I know this was a lot of ideas for a lot of people who have not been used to this. It's maybe too much, okay? So we're gonna divide this up into 6 weeks. We're gonna have special team that's gonna do animations, and you're gonna understand everything you need to know as you get started with our clinical studies in our University of Neurosurgery. So we're gonna create the system for you that you can understand all these principles as you engage in this activity with us, okay? Now this is a large group as far as questions are concerned. I just want to share something real quick here before we get into for medical students, for neurosurgeons want to become PIs in these studies, this is your QR code. For medical students, you get to select a subspecialty neurosurgery that you want to pick to get involved with to become in a large clinical trial. And this is for residents, okay? So this is a process, we're putting this together. As part of you getting involved in these research projects, you will be asked to take this module that we're producing that it will only take a few weeks, 1 hour a week, for you to understand all the concepts that were presented in the lecture earlier today, okay? And well, while I'm at this, let me stop share and let's read some questions that have been, I mean, everybody's thanking you for an excellent presentation. I mean, it's just a lot of stuff. So Julia is asking, yeah, so Julia is asking the general question that you raised at Ignatius, how to break this paradigm of poor research production in underdeveloped countries, other than investing in quality, considering the lack of investment and interested mentors. Do you want to say something about that, Dr. Ignatius?
Maybe you can answer that. You know?
Okay. Yeah. So I think what Dr. Ignatius is saying is, listen. And what I'm saying through the AUN, we want to equilibrate around the world knowledge in neurosurgery, in every part of neurosurgery, and research opportunities. This should not be a limiting factor anymore. Okay. It was a limiting factor for a long time, but we're saying all of you can be engaged in high-level research and clinical studies. You know, we start, of course, we're hoping, you know, for level 2 kind of studies. And we're also hoping through these groups to produce really nice systemic reviews and meta-analysis. You saw there are a lot of guidelines how this can be done. So all of you will have access to this, okay? So you do not have a limitation. This is not bench research. So if we're talking about bench research, can you go to a lab in your medical school? Yes, I fully understand there are a lot of limitations. We're giving you an opportunity to get involved at the highest level of clinical studies, no different than a student sitting with me here in the United States, a student sitting in Western Africa, or a student sitting in Asia. All will have the same ability, same level of opportunity to get involved. So what we're trying to say is that you now will have an opportunity in the field of neurosurgery to be at that level. And we will give you the basic framework through this module for you to understand everything as you're starting your research. Understand all the terminology that Dr. Ignatius just mentioned to you. So you understand what kind of study you're going to be involved with and what is the right way to do this stuff. So this was a kind of a high level introduction lecture, and we're going to produce a module that's really basic principles. We're not going to get into the weed or a lot of minute detail. You're just going to understand the basic differences between the various things, the types of studies, biostats, relative ratio, odds ratio. What does it mean you're looking at a paper? What does the p-value mean to you? You know, those kind of things. I want you to understand that as you embark with us on a project. So that's really my answer to that. Yes, we will provide the video of this to you guys. It will be on your forums that we have, so you could review that video again for you and for the people that are not here today. Anna has a specific question to you, Dr. Ignatius, if you could read that while you're reading it. Mohat, you had a question?
Yes.
Please go ahead.
Thank you for this great webinar.
We cannot
hear you.
You're cutting out. Please unmute yourself.
The university when I apply for research position is to change a lot.
You know, Mahat, I think your audio is really cutting out because of the internet. If you could write it in the text, that would be great, please. Unfortunately, it's cutting out. Okay. Yeah, Samuel is asking the kind of study designs. Of course, you know, you have many opportunities. You have the opportunity of doing bench research that'll take years, and you can be involved with that. You have opportunities to be in clinical studies like we are going to be working with you. The most important thing for a neurosurgeon scientist is translational work, okay? How do you translate something that's happening into the clinical world? That is the biggest and the most important area I want you to think about as you engage with us in the future of research. That is going to be really, really important for you guys to be part of this process. Of course, those of you who want to go and do a PhD and want to be an experimental scientist, want to do bench research, we want many people to do that for sure. In this format, in the University of Neurosurgery format, we really are developing with you the clinical studies, the clinical part of the neurosurgeon scientist program. So that's what we are, you know, we're planning to do. Ignatius, do you want to say some comments about a couple of the questions that are asked?
Well, I just want to add that, I mean, most of the challenge faced by the younger ones in LMICs is they don't have access to funding. I mean, we started with nothing, you know, funding shouldn't be the barrier. If you have a good idea, I mean, today in the global world, there are always going to be people who are ready to assist you, I mean, put you through. So don't worry about the financial aspect. Just try to develop the idea and people are going to be there to assist you. And this is a platform which is available already, being connected to thousands of medical students across the world. It's, I mean, something which was not possible so many years back. And we were able to talk to so many people this evening because of Zoom. Before you needed to maybe book a flight ticket, pay the hotels to travel to attend such, so get such lectures. So this shouldn't be a barrier. So just look at the positive part of it, and I promise you things are going to be positive. And we all need to be engaged, actively engaged. As I told you, the concept is clear. We want to develop the next generation of academic maybe surgeons or neurosurgeons. Okay, you find, as I said before, you find a lot of people in the hospital, I mean, doing kind of basic surgery. I mean, basic surgery is not going to change anything. That is looking at things at the micro level. You need to look at neurosurgery from the macro level. Okay, and that's where education and training comes in. That's where research comes in. That's where global health comes in, because you're never going to change anything if you look at things from the micro perspective. You need to look at the big picture.
Yes, yeah, that's an excellent point. And you know, Sherry is asking a question about the limitations we'll have with our clinical studies. Because we have people from many different centers getting involved. So we're gonna have some standard protocols and every group. So once, you know, luckily we have a lot of neurosurgeons who want to be PIs in doing these studies. Once we design every group under a neurosurgeon, each group will tackle their issues individually at their centers. What are the requirements? We're gonna have our own standard ethics board that's gonna look across the board at all data and to protect, you know, based on US standards, right? But if there is if you are from a center somewhere in the world and they want some specific stuff, you're gonna have to help with that because you are our representative in that university. So we will make sure that everybody's needs are met and all, you know, regulatory requirements are met. But that will be done at each group, which is gonna be, every research project will have its own group. And we will have individual discussions based on where those centers are and what their individual needs are. We are really very interested clearly in the prospective cohort studies. You know, that's really our big interest from you know, primary research. But we are not at the initial stage interested in or can at this point do randomized control trials. It's just too early for that. We need to get our base together until we have a strong group around the world, and then we could define specific things we could do. So we're looking at cohort perspective kind of studies, but of course we're very also interested in high level systemic reviews and meta-analysis. Which is really very doable in a group like this, where you guys can do really some big reviews. There are some great ideas with a large group of people who can come together to do that. Those are the two main areas we're interested in right now. And I think we can meet those requirements from that standpoint. I know for a lot of you, this has been over an hour, coming to an hour and 20 minutes. It's a long session. So, okay. Okay, Mohat, your question, I missed it. Can you repeat the question, please? All out. Okay. Yes, go ahead.
I see when apply any research or not.
Okay, I'm really sorry, Mohat. The internet connection is really poor. Let's connect offline, okay? Let's connect offline. Dr. Ignatius kindly gave you guys his email as well for specific questions you have for him. So you could contact him as well. I apologize for that, Mohat, for the poor connection. It is good to be with you guys. And you know, there's a lot coming up. I look forward to seeing you all, you know, in one of these forums, okay? And of course, we have our annual meeting in Granada, Spain this year in September. I hope those of you can be there. And it's been really a pleasure for me to be with you guys and, you know, and to really do this. And we, of course, will have a lot of meetings with the Research Institute, with every group. We're looking for some really good people for animation. We have a very good content group for the research module, but we do need a very good animations group. So any of you are interested, let us know to be involved with that. And this research module is coming soon. All you will get to take it and be part of our research projects. Dr. Ignatius, Esene, thank you so much for being with us. And you know, we're gonna have a mentorship program, all of you know. We're gonna have a lot of mentors from around the world, and he's gonna be one of our mentors, okay? So you get to pick him as your mentor, So you're going to have a whole mentorship program that we're creating for you from leaders from around the world. And so he'll be one of the mentors. You will also have the opportunity to have you as your mentor. So good to see you all. It's my pleasure, my honor, and I look forward to seeing you all soon in many things that are coming up. Thank you so much all.
Bye.
Thank you, professors. Have a nice day.
Thank you so much, Professor.
Bye, Prof. Thank you.
Thank you, Professor.
Thank you, Prof.
Thank you, Prof. Thank you.
Appreciate your work, professors. Have a nice day.
Thank you.
Thank you
So much.
Yeah, so I'm finalizing the document I had to send. So
Yes, please. That's the only thing that's left.
Yeah.
If you could get the document to our team, and then we're gonna set up our next meeting with them.
Okay.
As soon as you know we get the document, we'll have a meeting with them and set the first 2 lecturers to go. Okay.
All right. Okay.
Yeah. So thank you so much. I really appreciate it.
Thank you so much.
All right.
Thank you, Professor.
Thank you. Lojane, are you here? I just, if you could send me a message via WhatsApp. Mu'adh, I'm so sorry we could not hear your question.
I will send you a record in WhatsApp. Is it okay?
Yeah, please send me. Yes. I can hear you now, by the way. I don't know why I couldn't hear you before.
I want to tell you that I am going to move to the US, inshallah, by the next year. Okay. You know, as IIG, I have to improve my CV for residency. My question is this module going to change my CV to get a research opportunity in the US or not?
Say that again. Say that again.
Do this module going to improve my CV to get a research position in the US or not?
Yeah, I mean, by getting involved in this research project, you're opening a lot of doors for yourself. Research opportunities improve by having done more research. So if you've done a big project and your name is on it, then that opens up more opportunities. That is how it works.
Yeah, thanks.
Of course.